is my pleasure today to introduce you to Claus von Zychlin, the President and CEO of Mount Carmel Health Systems. Like the rest of us with very difficult last names, we just call him Claus. As many of you know, Mount Carmel Health Systems has been serving our community for more than 125 years. Mount Carmel is a member of the Trinity Health system, one of our nation's largest Catholic health systems. Claus took the helm in 2006 during a very challenging time in the healthcare industry. He has led with strength, courage, and fortunately for his sanity, a little bit of humor. Obamacare has changed the way the healthcare system works today, as you can tell by the many clinics and wellness initiatives popping up everywhere. Mount Carmel has taken great strides in changing their delivery system, with historic investments into our marketplace of over $700 million. I am impressed every day how Mount Carmel reflects on its roots and its mission, while making so many changes to accommodate the new world of healthcare. I met Claus a little over 3 years ago. He is actively involved in all things health-related, the Ohio Hospital Association, American Hospital Association, and the Greater Columbus Infant Mortality Task Force, just to say a few. But he's also a very proud father of 3 children, and as I found out recently, enjoys biking with his wife, Sue. Claus is not only a great leader, but a great teacher. I have learned a lot about healthcare over the past 3 years, and I know you will learn a lot today. Please help me welcome Claus.
Good afternoon. Thank you for inviting me to be here. Kathy has been a great board member and asked a lot of the right questions, and clearly with her business in Franklinton is particularly concerned and involved in the things that we're going to continue to do and will do here. So, So thank you. When I was coming over here today, I didn't realize this, but this week represents the 50th anniversary, actually signed into law on July 30th, 1965 by President Johnson, the Medicare and its resultant Medicaid Act. And when I was reading the material that came through that talked about this, it also talked about how, as a country, we were concerned about how we were going to pay for Medicare, but we also talked about the fact that it was important that we do not let our seniors go without health care. Now, there are also, I'll speak to in a little bit, some of the changes that probably came out of the Medicare Act that in fact may have not gone the way that we would have liked them to, because really we talked about paying for health care, but we never really talked about how we create a system of health care and how do we deal with patients' illnesses rather than just dealing with intervention. So with that, I'm going to mention a little bit about who we are, and then maybe a little bit of history about where we've been and the kind of the monumental change we're going through, and then a little bit about Mount Carmel and how we are in fact adapting to the new healthcare system. And so I can never start out without talking about Mount Carmel as a health ministry of the Catholic Church and as faith-based, and our mission is we serve together in the spirit of the gospel as a compassionate and transforming healing presence within our communities. And that is in fact why we're here. The sisters were brought here in 1885 by Doctors Hawkes and Hamilton, and they came here to run what is now, as we know it, as Mount Carmel West. And then in 1903, we started, interestingly, our College of Nursing, which has been with us that long and now boasts over 1,300 students, a strong program that not only teaches undergraduate but graduate, and this year will begin doctorate level programming for nursing. And then in 1971, we developed Mount Carmel East. Now, the interesting thing about Mount Carmel East is that the sisters back in 1909 bought land, which is where Mount Carmel East is now located, in which it was farmland. And it was actually the farmland where the sisters, when they wanted some respite from day-to-day care of patients, would go out to the farm and raise food with which to feed the patients that were in their hospital. And then in 1995, Mount Carmel St. Anne's became part of Mount Carmel, and then in 2007, we acquired Mount Carmel New Albany. And so we, in fact, are a health system that is committed to this community, was founded to support this community, and in fact, this year, we will provide this last year we provided in excess of $93 million of community benefit. So what are some of the things that we talk about in community benefit? Well, these come from the mission-driven component of who we are, and these are things like our Welcome Home program, which provides home care services for new mothers in helping them with the development of their children and the care at home, something that is unfunded and is supported by contributions and funding through our foundation. Our outreach mobile coach, which provides emergent care in different parts of the city. Our street medicine team, a unique program that's been nationally recognized where we have a team of very dedicated people. This couldn't be done without, it's one thing to provide the services and pay for it. It's another thing to provide the service with people who are committed to going out into the streets and out into the woods and caring for patients who do have no other way of receiving health care. And then one of our new ventures down in Franklinton, our Healthy Living Center, which we created to provide a holistic approach to health care, which includes education, cooking classes, chronic disease management, and education. We also have a partnership with 20-plus churches in providing health community care, and we also are partnering with the federally qualified health centers to provide care outside of the emergency department for patients that really do need primary care and not just episodic care. So we are a health system with more than 10,000 colleagues, 1,600 physicians, and over 800 volunteers, and we are located throughout the city. We're about a $1.7 billion company. We provide, as you can see here, over 76,000 admissions, 261,000 ED visits. We also have, besides our College of Nursing, we provide graduate medical education with about 100 house staff. We also have an insurance program. We have our ambulatory program, and we have our physician partners. So a large multi-program system. So just to spend a few moments about healthcare changing. You know, we talked about the Accountable Care Act, transitioning healthcare no differently than Medicare transitioned healthcare back in the 60s for people who did not have money, Medicaid, and then also for the seniors through Medicare. We also know that back after World War II, the government had wage freezes, and how did companies get into paying for health care benefits? Well, companies got into paying for health care benefits because with wage freezes, one way to offer services or offer a differentiation for recruiting employees was to start offering benefits. So in essence, employers got into health care not by design, but as a vehicle through which to provide alternative reimbursement or alternative payment for employees. And so companies got into it in an episodic basis. I will pay for health care when you need it, not for health care for prevention or in keeping you healthy. And so we never really created a healthcare system, but we created a vehicle through which to pay for healthcare. And so when we talk about transitioning to where we're going to now, we're really talking about how do we transition from a system, not even, we call it a system, but how do we transition from episodic care to value-based care, continuity of care? And so there are three drivers right now that really fundamentally are forcing us to change. We can talk about the Accountable Care Act, we can talk about any other plan. that people talk about, but we can no longer afford the way healthcare is delivered today, and with the changes coming forth in healthcare, we do have to make changes. So, you know, healthcare is a $2.8 trillion business, 9,000 per person. It's 1/6 of the GDP, and it continues to grow. I was at a conference back in 2006 where one of the premier economists of our time in healthcare, Uwe Reinhardt, said, if healthcare continues the way it goes, although his timing is off a little bit back then, he said, but in the year 2020, if you want to take your significant other to a movie and dinner, you'll have to check into a hospital because 100% of GDP will be spent on healthcare. Now, he's a little off in his timing, but in essence, we continue to see that kind of growth. Now, this slide is one that, when we talk about the price of healthcare and we talk about historic healthcare revolves around hospital beds. We drove patients to the hospital. It was more efficient to care for them that way, and again, healthcare has evolved with so many things that historically have been inpatient-based. So we drive to the inpatient side. But in reality, if you look at the cost of healthcare, the highest cost of healthcare is in the hospital. And actually, where we as consumers of healthcare prefer healthcare is not to be in the hospital, but to be at home, right? So the quality of healthcare, the quality of life is driven by not being in the hospital, but being somewhere in familiar surroundings, being someplace with family and with support. And so our historic healthcare has been to drive people into the hospital, which is also the highest cost, lowest satisfaction, and where we really should be moving healthcare is out of the hospital and into the homes and other centers where we feel more comfortable and we feel more relaxed. And so price is, there's a misappropriation of how we're set up as a healthcare historically, which is to drive you to the highest cost provider rather than driving you to the least cost process. So in the last decade, or the last century, actually, we've increased life. When we talk about population and how population affects healthcare, not only is it a growing population, a growing aging population, but also with 30 years of additional life, there's lots more going on in healthcare around chronic disease. And so when we talk about chronic disease and we talk about healthcare as a system, you know, this is really not that uncommon because we talk about what's the best way to reduce the cost of healthcare. It's actually to prevent healthcare. And so some people would argue that, and statistics I've seen, is that upwards of 75% of healthcare can be affected by our lifestyles. And so when we talk about going forward in healthcare and we talk about how are we going to change the spend on healthcare, we have to start talking about how we as individuals take responsibility for our own healthcare and how we look at prevention rather than just intervention. So in today's world, because of longevity and technology, one of the most expensive parts of healthcare now is chronic disease management, because we're all living longer, new technologies are coming along, and so this is going to continue. And so when we see the cost of population, we're going to continue to see that evolve. And finally, on demand. So we have an insatiable appetite for healthcare services, and you know, I always hate to say this, but you know, we do know, as the old saying is, there are two things in life that are guaranteed. One is taxes, and two is death, right? And so we in healthcare recognize, though, that there are so many interventions that we can create. And we also have created that demand through new drugs, new technologies. And then one interesting component, back in the early 1920s and 30s, we really only had two types of physicians, right? We had surgeons, two types of doctors. We had surgeons and we had clinicians. Now, there's registered something like over 300 specialties and subspecialties of physicians that are in fact practicing in every part of our body, right? And so that, not to say that technology is not advanced to that point, but that also drives. And then our system has historically rewarded us for doing more tests, more services, because that's how historically we've been paid. And so another component that is evolving in the healthcare industry is, from a historical perspective, is healthcare was historically benefit-driven, meaning we all received benefits, and so we didn't pay directly for healthcare. And also from a consumer, and because of that, we tolerated services in healthcare that were much more worker-driven than consumer-driven. What I mean worker-driven is most of the times hospitals and systems were built around the worker, 3-bed wards, 5-bed wards. Why it was more efficient for the worker to care for the patient that way, because we could see 4 in a row, 3 in a row. And today we're moving into a consumer-driven world where, like any other business, 24 hours, 7 days a week, people want to have access and want to be able to do things. So we're seeing this transition around demand on how we move from worker benefit-driven to consumer pay, consumer demand. And so we move into this monumental transition that we talk about, and it is because this transition is going to happen. The last healthcare system we've been part of, or the healthcare process we've been part of, has been going on for well over 50 years, right? So before Medicare, even back to the point of the labor board of when companies started paying for health insurance, we've been working under the same system for the most part with just a few tweaks here and there. Now we're going through, with the Accountable Care Act and the transition and the cost of healthcare, we're going to see this transition happen in a much shorter time than the 50, 60 years we've been living at with the system that we're in. And so here are some of those key phrases. Healthcare used to be a solo sport, single doctor, single hospital, and now we're going to a team approach, right, where it's not just the doctor, but it's other caregivers and how we integrate them with one another. We're going from sick care, where we wait till you're sick to intervene, to where we talk about prevention. How do we figure out ways to keep somebody from getting something? We talk about going from reactive to predictive. With genetics and everything else, how do we predict what could happen, and can we intervene before that happens? We go from the whole person, body, mind, and spirit. We go from body part to body, mind, and spirit. We go from one size fits all to personalized health care. And I can go, benefits-based to direct payment. As we, as the insured, have bigger co-pays and bigger deductibles, there's more and more decision-making that we should be a part of in where we go. And then we talk about variation from standardization. And this is another historical transformation. As healthcare, the concept is called industrialization of medicine. We're really moving from a cottage industry of medicine, where each doctor did his or her own business, to where we now are creating systems of care, because we can't just deal with a single intervention, but we have to look across the continuum of care to say, how can we help you, not just today, but tomorrow? How do we keep you from being readmitted? How do we keep you from being admitted in the first place? And we can't do that in each little ivory tower, but we have to do that in the process of creating systems of care, which healthcare really never has been before. Healthcare has always been islands of care that have just worked together sometimes and sometimes not so well. Also, uninformed to informed. How do we as consumers have to become part of the decision-making process of where we go? And then third party versus our own accountability. Now that we start having to spend more of our own money for healthcare, how do we participate in a meaningful way? And so when we talk about redefining, let's just talk briefly about some things that in Mount Carmel. We've kind of designed our processes in around 3 core buckets to serve the patients, right? And historically, the only bucket we really had to worry about is operational excellence. How did we deal with day-to-day when a patient showed up, how did we deal with them day to day to day? The world we're going into now is population health management. That is, how do we look at prevention? How do we look at caring for a broad population base in a way that is continuum of care rather than single interventions? And then network is, because healthcare is no longer hospital bed-based, because more and more healthcare is being provided outside of the beds, and the beds now, in some ways, can be spoken to as a failure of the healthcare system to take care of somebody. We have to redevelop our network so that we're caring for patients at the right place, at the right time, in the right way. And that's not anymore always in the hospital. In fact, it's going to become less and less on the inpatient side. We also are talking about how do we, so when we talk about the systems of care, we call this kind of the plaid model, which is rather than each of these vertical axes being independent of one another, we now have to create systems that go across all sites of care, across all methodologies of how we care for a patient. So how do we coordinate patients, not just vertically while they're in the four walls of a hospital, but how do we help coordinate patients' care pre-hospital, during hospital, post-hospital? How do we keep them out of the hospital rather than coming into the hospital? So that also requires different payment mechanisms where we get rewarded for keeping people out of the hospital rather than getting paid for how many beds we fill. And that's really kind of the center part of how we, in fact, are developing. And so when we think about population health, new concepts for us that we're building out right now and building in our systems is how do we create care coordination, not just for while you're in the hospital, but how does care coordination work predictively so that we can keep you out of the hospital? How do we do disease management so that we can attack issues early in the process rather than at the end of the process? How do we start building these new payment models that are coming out of Medicare where we get paid for an episode of care, we get paid a single bundled payment to care for somebody for 90 days? How do we build those systems to allow that to happen? All of which we're working on not only with the commercial payers but also with governmental payers, Medicare and Medicaid. Under operational excellence, we talk about one Mount Carmel, right? And what we mean there is instead of having 4 hospitals, we really say we have one hospital in 4 locations. So and I mentioned earlier about industrialization of healthcare, we're no longer talking about 4 separate hospitals. We're now talking about how do we take our 4 locations and operate them as a single entity so that we can create commonality of service, commonality of purpose, and we can right-size those facilities to meet the needs of the patients that we serve. And so one example that I could use is we have New Albany, which is a world-class joint and spine center. It ranks among the top 2% in the country for the work that it does. And so the team that runs New Albany is the same team that integrates with our other campuses so that we run a single orthopedic and spine program across the whole system, operated the same way, same protocol, same processes. We have done the same thing in cardiac services where we take our whole cardiac team, and historically cardiologists and cardiac surgeons were stationed at a single hospital and they kind of competed with one another. Now they're all members of the exact same group, and so the surgeons, the teams, they will go where the patients are and they will operate under single protocols, under single processes so that we create standardization and a much higher degree of quality of care. And so those are things that are somewhat historically against the mindset of how we as healthcare workers have worked in the past, and it really is the future of where we are going. So then finally, I'll talk a little bit about our network. And we're no longer, our goal is no longer to be hospital bed centric. Not to say that we still don't need those modernized upscale facilities, but they are going to move to the end of the food chain rather than being at the front of the food chain. So we talk about our network of primary and specialty physicians, our fitness centers, urgent care, wound centers. You can go through this list and see that really this is about creating an overall continuum of care. And one of the things that we would also say is no one person, no one entity can do it all themselves. And so when we look at our program, a lot of these things we do ourselves, but we've also created partnerships. So 2 years ago, we created a partnership with Ohio State University where we partner with them in a number of areas, neurosurgery being one, physiatry being another, and work that we're doing to say, how do we create value in this community rather than it's community value rather than individual value. And some of that, the benefit is we could go out and recruit certain doctors ourselves, but by partnering with Ohio State, we give the doctors who are here the additional volume that benefits both of us, and it gives them the ability to specialize in a way that they couldn't do if they didn't have the volume to keep the core group busy and to keep them competent. We also have done recently, you may have read, we did a joint venture with Health South where we're going to build a rehab hospital. And again, they're a national leader, and we are, in fact, we provide that service. We need that service as part of our network, but we've been able to create that network, not just by ourselves, but with other partners to do that. And we see that happening more and more to do, because it's so complex and it requires such specialization, we can't do it all ourselves. We'll continue to grow those partnerships. We also have one with the federally qualified health centers where we're working with patients that are disadvantaged who use our emergency department as an example. We have some patients that come into our emergency department in Franklinton over 60 times a year. That's really not the right place for them to receive care, but if we can redirect them to one of the federally qualified health centers where they can get primary care, that really benefits the system and the individual. So, as we look at modernizing our campuses, which I mentioned earlier, over $700 million worth, we are building them very different today than we would have if we'd have done this 5 or 6 years ago. And that is, we're building them smaller. We're building them more efficient, where we're going to share services between the campuses. We're not going to continue to do everything at every location because we're going to create critical mass and become more efficient with our physical plants, because we're going to distribute those services throughout the community through a series of other vehicles, whether it be the hospitals with beds, or like in the case of Mount Carmel East, we're in the process of, it'll be 381 beds, which is less beds than what was built with today. Private rooms are more efficient, but also we believe with shorter lengths of stay and with the ongoing technology, fewer and fewer people are going to be admitted to the hospital, and we're trying to build these facilities to be fiscally responsible with where healthcare is going, which is out of the hospitals. Mount Carmel West will be our health and educational campus. It'll continue to be a thriving outpatient facility. It'll be, in essence, a medical campus without beds. We'll have comprehensive healthcare services there, our teaching center, we'll have a college of nursing, and we're also hoping that with the infrastructure that's built there, that we will partner with other players in this market to continue to develop healthcare services on that campus that can benefit the greater community as well as the Franklinton community. In Grove City, if you look at the footprint of this community, Grove City is really the last quadrant. The southwest quadrant is really the last quadrant without hospital beds, and with the growing community, it fits the footprint of where we are going to put some beds. And if you look at the Franklinton area and you overlap the radius there are more beds per 1,000 overlapping in Franklinton than any place else in the community because of all the density of hospital beds that are in that area. And then our second tier are these outpatient comprehensive campuses that provide everything short of hospitalization. So we have one in Grove City, one at Diley Ridge. We have one going up in Delaware, and we have a couple of others of these planned that are going to go around, and these are, again, facilities that are designed to meet patients' needs that don't need to be hospitalized and don't, I mean, I know myself when I get it, go to the hospital, I hate that complexity of the big facility, and being able to go to an outpatient center, it's a lot less stressful, a lot more relaxing to go there when in fact you have to. We're also partnering with, Columbus is fairly interesting. There are 29 or 30 freestanding surgery centers that are up and running. So clearly the community prefers the outpatient setting over the hospital setting. So they're part of our partnering as we build this comprehensive network throughout the community, which will take existing resources to create a system that is lower cost, higher value in service, and ultimately provides the best value in the community from a price service continuum. So for us, it's about better health, better care, affordable costs, and it's how do we are creating that network to create a distributed system that can meet the healthcare needs of the patients where we're going with healthcare, not only with technology, but also with the outpatient transformation and the quality of the care that's provided. So that's my few words, and I would certainly be happy to answer any questions, any comments that you might have. I was told this is not a bashful group, so I'd be happy to answer any questions.
This is not a question, but a accommodation, if you will. Several years ago, a friend of mine's mother was admitted to Mount Carmel West, unconscious, and the family had some concerns about prematurely removing my friend's mother from the respirator in a way that might conflict with the family's religious needs. And worked with the, I was asked to get involved. I worked with the family's rabbi and with the staff at Mount Carmel West, and we found them incredibly sensitive, accommodating, and cooperative toward the family's religious needs. Worked with us to find a solution that would accommodate both the needs of the hospital and the religious needs of the family. And I just wanted to commend the Mount Carmel system for the sensitivity they showed.
Thank you. Did you hear that, Kathy? Good. All right. Thank you. Yes.
As you centralize services in certain areas, what do you do with emergency situations? Are they still accommodating in the different areas?
Right. So emergency services will continue to be spread throughout the city, and you know, with fairly rare exceptions, in today's world, you can bring somebody in and you can stabilize them, and then you can decide what the right thing is to do. I mean, one of the early examples is open heart surgery. You know, it used to have cardiac surgeons that were on call 24 hours a day, 7 days a week because of open heart. But now there's virtually, and you as a patient would never want this. You know, you wouldn't want a surgeon at 3 in the morning to have to get up and do your open heart. And there's very few open heart surgeries that are done at night anymore because the patients are stabilized and they can be moved to the right location. Yeah. Yes.
You mentioned, I think, what is expected to expand the outpatient versus the admitted facilities. Are there any other areas and specializations, types of care that you expect to increase and or decrease over the next 5 years or so?
So, you know, one of the most puzzling and one of the most difficult processes nationally, and we have the same issue here in Central Ohio, is how are we going to deal as a system with behavioral health services? And it's not just inpatient, but it's outpatient and all facets of that, because it's one of the least understood, lowest reimbursed illnesses that we as a health system are tackling. And yet it involves, I think, about something like 25% of every patient has, or higher. How high should I go? A lot higher, okay. So a high percentage of patients are that we use have mental health issues, and we as an industry, we as a system have not figured out how to deal with that yet, and we're going to spend more time over the next few years trying to figure out. We've done a pretty good job in Columbus, where the 3 adult health systems have worked together to try to deal with emergent psychiatric needs, but we still have to figure out a way to make it a part of the system we operate. And then I think we also have to recognize that there are certain high tier services that it doesn't make sense for everybody to try to duplicate. And we have to, if we're really committed to serving the community, we have to figure out how to collaborate as competitive as we are to make sure that we are in fact creating the opportunity for the highest in value for some of these new tiered services that are coming in, rather than just to do them for competitive reasons. Yes.
How would you characterize your business mission? Do you have one? For example, in terms of stockholders, or what's Trinity's role? How do you present yourself as the leader in the business case?
Well, we have to make sure that we make at least as much as we spend. I mean, so, but I think, I mean, in reality, we do have metrics against which we measure ourselves, and you know, that is, you know, you could say, if you use it, is that we meet AA expectations in our financial positions, but we also recognize that as you know, I once had a sister tell me no margin, no mission, and that's true. I mean, we need to make enough to replace plant and equipment. And, you know, this community, some people have talked about, you've seen all the cranes out there, and some of that's true, but if you look at the age of our plants compared to other communities around the country, they're actually all pretty old. And so technology has changed enough that, you know, operating rooms, for instance, that are still inpatient are virtually twice the size than when they were built in the 60s and the 70s. So we do have to replenish what we have, and that's really we have to make enough to be able to replenish and grow, but not enough that we have to pay stockholder return, because that's not what we're about. So, yes.
Yeah, I know that Nationwide Children's Hospital has a capitated system to handle their Medicaid patients. Is anything like that happening at the adult hospitals, and how else can you handle Medicaid patients?
Yeah, so the governor is in the middle of revamping Medicaid, all right? And historically, Medicaid has gone. The first step was there are 5 insurance companies that now handle all the Medicaid for the state of Ohio, and now we're in the process of figuring out how to work with them in a way that might involve capitation. It might involve some component of care. But part of it is there has to be penalties and rewards that are built into the system that allow us to encourage people to do things the right way. And the system is also not, we have to come up with different types of systems for patients who are on Medicaid, and you know and this may be somewhat of how we speak about it, but you know, Medicaid pays well below cost, and not just for hospitals, but for doctors and for other services for the most part. And so the right access to care, and also patients, long-term patients, chronic patients that have been on Medicaid, also that we have systems of care like the federally qualified health centers and others through which we can deliver care in a way that meets those patients' needs. So it's also a social process that has to be rebuilt, and so that's not going to happen overnight. It's going to take 5 to 7 years. Very different than than the pediatric population, where for the most part healthy, capitated rate because they can concentrate. So the answer is we're working on it as a system and as a state, but it's going to happen. It's going to take longer because, one, the complexities of how it's getting reimbursed, and two, the way that the care provided is not as efficient or effective as it could be. Yes.
I don't know how it looks from the medical side, but from the patient side, there's one area that I think it's almost impossible to find, if not outright dissatisfaction, minimal satisfaction, and that's the area of the so-called hospitalist. Do you see a solution for this?
All right, so I got to be careful. I got a doctor sitting there, but two things are happening nationally that you have to be aware of. All right, one is the practice of medicine is changing in a way that the social side of it is this: millennials, people our age, put their practices first ahead of anything and everything else. So they'd come in at 3 in the morning, they would do whatever it is that they needed to do. The world that we're going into, physicians, other specialties may see it, lawyers, et cetera, is personal lifestyle, personal quality of life is becoming an important part of most any professional's lifestyle, right? And so new doctors coming out and new practitioners coming out, they're committed to their profession, but no longer 24 hours a day, 7 days a week at all costs. The second thing with hospitalists is healthcare now is a 24-hour, 7-day-a-week basis, meaning that the cost of leaving somebody in the hospital, and if you take the doctor that comes in at, your personal doctor comes in at 8 in the morning or 7 in the morning and rounds before they go to the office, then comes in again at the end of the day to round again, that's 6, 7, 8 hours of practice of care that is being done by phone or by email or by something, when in fact hospitalists can be there 24 hours a day, 7 days a week, and care for patients minute to minute, hour to hour, et cetera. And because healthcare is moving at that speed, you can no longer provide healthcare remotely, and you have to be accessible in a much more expedient manner. So healthcare is changing to where you no longer, we have to care for the patients on a minute-to-minute basis. Can't be done with a doctor who's in private practice and is in their office seeing patients in between the day. And the second thing is the world we're going into as the new profession, the new people coming into the profession have a different expectation of their profession than those that were there, our age and before. Is that a fair, Rick, is that a fair depiction of the question? Okay, yes.
Final question, last
Okay.
question.
You mentioned that deductibles are high, and therefore patients have to select how they're going to get their care. I think that was something you were saying. Doesn't price transparency come into this? I would say medical pricing is the most untransparent commodity, if you want to call it that you can acquire. What's the solution to that dichotomy?
So you're going to start seeing more and more transparency over the next 3 years. It's going to have to, because if you're held accountable for paying the bill, you're going to have to start making financial decisions, and you're going to have to see the price. And so we're scrambling to be able to start being more predictive in what the cost of it. We can tell you what an MRI is going to cost, but we may not necessarily be able to tell you what an episode of care is going to cost. And that's where we have to get better at being able to price it, because whoever figures it out early enough you're going to make, if you can get a price and lock it in, you're going to go there rather than a place where we continue to say, hey, just trust us. And at the end of the week, you get a bill and you go, wow, where'd that come from? So, but it's a national movement, not just for Medicare and Medicaid and commercial pay, is to be much more transparent with where the prices are, especially as copays and deductibles continue to grow. So stay tuned. It's coming. We're getting hit with it almost every month with a new web page or a new somebody that says, I think I got the numbers. I'll show you. They don't have it, but we're getting there. Thanks.
Just a moment. Klaus, I want to just thank you on behalf of Columbus Rotary and accept this gift from Argo and Laney. If it's broken, let me know. Thank you, everyone, for your time and your attention. We'll see you next week. Be a Rotarian all week long.